Namaste. In this presentation, we are going to discuss about the management of gastrointestinal symptoms. As all of you know, symptoms are the complaints made by a patient. It is a physical complaints and usually sometimes it is so severe in palliative care scenario that it affects the quality of life of the patient. So, it is very important to manage the symptom, to treat them and make the patient as comfortable as possible. Gastrointestinal symptoms mainly we are going to discuss are nausea, vomiting, constipation, diarrhea, hiccups and intestinal obstruction. A large number of palliative care patients has gastrointestinal symptoms, particularly patients who are receiving chemotherapy, radiotherapy or other cancer treatment. They have got many of the gastrointestinal symptoms, but they are not made much attention and doctors focus on other parts of the treatment. We need to pay more attention as it causes morbidity to the patient, and sometimes these symptoms can be anticipated and can be prevented in advance by giving certain medicine. Like if patient is undergoing chemotherapy, we can give certain anti-emetic drugs to stop vomiting, so or cause less vomiting following chemotherapy. So, particularly ongoing assessment and monitoring of the patient is required, and background medication as well as whenever symptoms occurs, it should be treated immediately. Firstly, we will be talking about nausea, vomiting. It is a biological defense mechanism to remove toxic or harmful substance from the body after ingestion, and certain terms which are related to MSCs are nausea, retching and vomiting. Nausea is an unpleasant sensation, and because of that patient does not feel like eating. Second is vomiting, which is a forceful oral expulsion of the toxic substances from the body, and it is associated with contraction of the abdominal and chest wall muscles. Retching is spasmodic respiratory movements against a closed glottis with contraction of the abdominal musculature without expulsion of any gastric content, and regurgitation is without any muscle contracture, and it is silent expulsion of the gastric content into the mouth. About 40 to 70% of the patients who are receiving palliative care, they have nausea and vomiting, and it requires accurate assessment and good knowledge of anti-emetic drugs. We should also consider the alternate route of administration, as patient may not tolerate your medication when it is given orally. So, control of symptom by various drugs is possible in 60% of the patient. These are various causes of nausea and vomiting in palliative care patient. It can be drug induced because of chemotherapy, following radiotherapy, because of some kidney problem, high blood urea and renal failure, raised intracranial tension, opioid induced, these are the medication given for pain management, gastric irritation, intestinal obstruction because of the tumor, liver failure, constipation, gastric outlet obstruction, esophageal causes, and psychological. Many a times patient is too anxious because of the disease or because of the disease related treatment he has to undergo, and because of anxiety he feels nausea and vomiting. It could be because of the biochemical changes in the body following the disease, and hypercalcemia and infection. Following chemotherapy, nausea, vomiting following chemotherapy is the main reason and main concern in all cancer patients, which can be acute, which happens immediately on starting of the chemotherapy. It can be delayed, which occurs after 24 hours and lasts for 48 to 72 hours, and it may last for a week also. Breakthrough: the nausea vomiting is under control, but intermittently patient gets a severe and emetic episode following chemotherapy. Refractory: sometimes this chemotherapy induced nausea vomiting do not respond to any medication. And anticipatory: conditioned response prior to chemotherapy. Many patients they have certain beliefs in mind that following chemotherapy I am going to get nausea vomiting. So, by anticipating the things, patient may get nausea vomiting as soon as the patient enters the chemotherapy ward. So, these are various psychological issues related to chemotherapy and which causes nausea vomiting in palliative care patient. What happens if patient has continuous nausea vomiting? It affects the daily functioning of the patient definitely. Then patient is not able to eat anything by mouth, so likely to cause weakness and dehydration sometimes and malnutrition. Then patient becomes non-compliant to cancer treatment. Once he or she finds that because of chemotherapy there is so much of nausea vomiting, second time he will say I do not want chemotherapy. So, refusal for the medication, pain medication particularly, which causes like tramadol and all causes nausea vomiting, patient will be hesitant to take the medicine. This causes families distress into the family members and affects the nutrition of the patient. So, principle of treatment of nausea vomiting is to stop or reduce symptom frequency as far as possible, to establish compliance to the treatment, giving reassurance to the patient that by this treatment your nausea vomiting will be under control and you will not be having any distress. So, by giving all such reassurance and proper medication, principle of the treatment is to control nausea vomiting and to improve quality of life of patient. This diagram shows the pathway of vomiting center. So, vomiting center is into the brain, right, and that receives stimulus from the labyrinth, that is in ear, from the stomach wall and that causes, it stimulates the vomiting center into the brain. Sometimes cortex, this center receives stimulation from the cortical centers like past memory, fear, anxiety, anticipated nausea vomiting. So, that also causes stimulation of the CTZ, that is called chemoreceptor trigger zone in the brain, and which causes nausea vomiting. And we have various drugs acting at various level. Suppose nausea vomiting is from the ear, labyrinth, there are certain group of medicine which act. If it is from the stomach, then 5-HT3 antagonist and sphincter modulator drugs, which will like gastric sphincter or stomach sphincter, it gets tighten, and because of that the whatever content in the stomach is there, it comes out into the mouth because of after vomiting. So, there are drugs acting on it, and there are agents which reduces the inflammation of the stomach and decreases the nausea vomiting. Similarly, there are certain drugs which acts at the higher center, at the brain level, and causes suppresses the vomiting center and decreases the nausea vomiting. This can be benzodiazepines to reduce the anxiety and all, or histamine antagonist and all, which will reduce the stimulation of the vomiting center. So, routes of administration of the drug to control nausea vomiting is very important, as I said earlier, because of nausea vomiting patient will not retain any drug if it is given orally. So, as per the patient's condition we can decide the route. So, best is oral route, but if it is continuous vomiting you can give intravenous, you can give intramuscular or subcutaneous route, or by rectal suppository, or by sublingual route, and by transdermal patches. So, it should be treated by mechanism based and not one drug does not suit each and every patient. The mechanism of nausea vomiting will be differ from patient to patient. So, accordingly you have to decide the drug which will act on in that particular patient. So, first of all try to find out the cause of the nausea vomiting, whether it is because of gastric stasis, means gastric outlet obstruction. So, stomach does not allow anything to go further into the small intestine and patient vomits it out, or maybe because of the intestinal obstruction, some biochemical changes, drugs and raise intracranial patient. So, ask the patient to record the symptoms and response to the drug. Educated patient can maintain a diary and how frequently he got vomiting or nausea, and which event caused the nausea, and how it was relieved, whether he was relieved with the particular drug, particular dose of the drug, that he can maintain. First and foremost step towards management of nausea vomiting is the correctable cause or exacerbating factors like drugs. If you know patient is on tramadol and that is causing nausea vomiting, you can stop tramadol and find some alternate analgesics. Severe pain, sometimes pain which is not relieved also causes nausea vomiting. Any infection, cough, hypercalcemia and anxiety, all these precipitating factors should be considered. Then you prescribe the most appropriate antiemetic drugs depending on the mechanism which is causing nausea vomiting, and choose parenteral route if it is a continuous, means you choose IV. Prokinetic antiemetic which will act on the gastric stasis is metoclopramide. It will increase the it will open up the gastric outlet obstruction to some extent, and it will propel the food towards the small intestine. So, it is very effective in the small bowel obstruction. Drugs which act centrally on the CTZ, that is a vomiting center, is haloperidol, which is very useful, very much useful when the nausea vomiting is caused by the central stimulation like morphine induced nausea vomiting or sometimes anxiety induced nausea vomiting. General principle you should keep in mind that sometimes only one drug may not act and you have to give combination of the drug. Like a patient who is anxious and also having gastric outlet obstruction, you can give metoclopramide as well as diazepam to calm down his central nervous system. Multiple causes may require combination. Persistent vomiting, in persistent vomiting you can give subcutaneous route, that is just below the skin you insert a cannula and inject the drug. Of course, when you are using certain drugs like metoclopramide, it gives extrapyramidal symptoms, and one should keep in mind the side effect of this drug, and few of the drugs do cause constipation like ondansetron and all. So, this table shows on left hand side causes of the nausea vomiting, on other side is the treatment. If it is drug induced, usually haloperidol acts. If it is radiotherapy induced, usually ondansetron or granisetron is effective. If chemotherapy induced nausea vomiting, we have got multiple many antiemetic drugs, and many new drugs has also evolved in last decade or so, and very effective, and that because of that we can give chemotherapy very safely to a very large group of patients. This may be ondansetron, dexamethasone, metoclopramide, and NK antagonist erbipetant is a newly introduced drug since last more than a decade or so. If the cause of nausea vomiting is metabolic like uremia, you can give haloperidol. Raise intracranial pressure, again dexamethasone. If bowel obstruction, metoclopramide, or with colic, you can give buscopan or ondansetron. And delayed gastric emptying and gastric irritation, again you can give metoclopramide, domperidone and pantoprazole. So, these are the drugs which has been listed as per the etiology or cause of the nausea vomiting. Many of our palliative care patients are on opioid for pain management, and few patients are sensitive to opioid and they have severe nausea vomiting, restricting the use of the opioid. In these patients, usually the mechanism is because of the stimulation of the CTZ, that is central vomiting center, or increased vestibular sensitivity, gastric stasis, and particularly constipation. This is very common in patients who are taking morphine or other opioids, and constipation is very common, which can cause nausea vomiting. So, here the drug of choice is centrally acting drug, which is haloperidol, and if it is because of gastric stasis, you give metoprolol. So, in few of the patient you might have to give antiemetic drugs right with at the beginning of the opioids treatment. So, patient is not likely to get nausea vomiting. So, and can aggressively reduce and treatment is very important before reducing the opioid. Dexamethasone has got a very good role to play in nausea vomiting, particularly chemotherapy induced nausea vomiting. It reduces permeability to CTZ and blood brain barrier to emetogenic substances. It reduces neuronal content of the gamma aminobutyric acid in brainstem. It reduces inflammation at the site of obstruction like in gastric stasis or gastritis and all, and by reducing pressure on the intestinal nerve, it reduces nausea vomiting. So, review the dose of whenever you start the treatment, every 24 hours you review the dose, review the requirement of the number of drugs, and evaluate the cause repeatedly till patient is totally treated. So, this is just to list down the steps which we already discussed, like establish the cause, try to find out the pathway which is causing nausea vomiting. So, select the drug, you might have to select more than one drug, you evaluate every 24 hours and regulate the dosing and titrate the drug accordingly, and reassurance of patient and family is very important in and these are some of the non-pharmacological means to treat the nausea vomiting. Patient should be sitting in a fresh air with cool atmosphere and proper bed rest and good oropharyngeal hygiene, oral hygiene, and keep the mouth clean. Nurse in upright position. Sometimes smell of certain food also causes nausea vomiting. So, isolate the patient from the surrounding of the kitchen where he is likely to have such smell. Suitable distraction, whatever he is interested, like in music or watching TV or reading book, give that opportunity to him. Reassure, counsel, support, wear loose fitting clothes, and limit sound. Sometimes patient, whenever you are sick, you know that you do not like sound or light or anything. So, make him comfortable whatever way they want and call the doctor if it is not controlled. Distractions, like many people can practice self hypnosis, biofeedback, and more useful in anticipatory nausea vomiting, muscle relaxation technique, meditation, relaxing technique, and feeling they should feel that now this thing I can control myself. That type of assurance should be given and reducing the feeling of helplessness. What type of nutrition they should be given? So, they should, patients having nausea vomiting should take small frequent meals rather than large meals, and during the time of the day when they want to have meal, eat better, like most of us can eat better in the morning hours during breakfast, and night hours usually patient does not feel like eating. So, give them proper food at the proper timing. Then more of a drinks, liquid diet, and do not force the patient to eat. In presence of nausea vomiting, this is very important. Give the food of their choice, and cold food or at room temperature are better tolerated. Avoid very fatty food or spicy food or very too sweet food. Avoid fiber which causes so much of bulk in the stomach. So, and avoid carbonated drinks. These are the dietary advice given to the patient who are suffering from nausea vomiting. Someone else, someone cannot cook the food while having nausea vomiting. So, somebody else should cook the food for them. If he is having difficulty in eating special food, like diabetic patient having restriction in eating sweets, but during nausea vomiting he may feel like eating sweet, though remove that restriction for few days and tell them to eat whatever they like and give them relaxation. A dietitian also can be consulted. Management again consists of documentation also, proper drug which is given, exacerbating factor, reducing factor, review after 24 hours, more than 1 or 2 antiemetic, and consider the route. Now, we will talk about constipation. As a lay person, we feel that constipation is okay, regular, it can happen to anybody and it can be relieved, but it is not so in cancer patient particularly and patients who are on palliative care. So, what is constipation? It is a subjective feeling, and what the patient says you have to believe, and his normal habit may be twice a day or once in 2 days. But when this normal habit is disturbed, it is called constipation. About 45% of the palliative care patients are constipation on admission. What happens if constipation is not treated? Patient will feel heaviness in the stomach, abdomen, incomplete sensation of incomplete evacuation, bloated feeling. Constipation may lead to nausea, vomiting, abdominal cramp, pain, bowel obstruction, overflow diarrhea. Sometimes the hard stool is impacted into the rectum and some soft stool coming out frequently. So, patient may feel I am having diarrhea, but in fact it is because of the constipation and urinary retention. There are many causes of constipation in palliative care setup. Many pharmacological, many patients who are on opioids, that is morphine and like drugs, 90% of them have constipation. Then patient taking antidepressant, anticholinergic drug, anti-epileptic, antiemetic, antacid, all these patients are likely to get constipation. Then metabolic causes, dehydration. These patients take less fluids orally, less water orally, water intake is very much less, that causes constipation. Hypercalcemia, hypokalemia and uremia. Then diet. Most of our cancer patients, because of overgoing treatment like chemotherapy and radiotherapy, they cannot eat much. Sometimes disease itself causes anorexia, so they cannot eat much. So poor appetite, low fluid intake and low fiber intake can lead to constipation. Sometimes they are put up in hospital for many days and they are not able to attend the natural call because of the unfamiliar surrounding, they get constipation. Neurological problems like spinal cord compression, sacral nerve infiltration will cause constipation. Structural, many patient has got tumor lying on the rectum in the pelvis, or radiation induced fibrosis and painful anorectal condition will cause constipation. And others are psychological also, like depression, weakness, immobility, inactivity, sedation, age related constipation. So these are the various causes of constipation. First of all, assess the patient, try to find out what was his normal frequency, what was the normal way he used to pass the stool, and what is the condition now, what is the situation now. Ask them when the last bowel movement was taken place. Many a times we do not ask this and we just ask the patient, do you have constipation? Patient will say yes, but when you go into the detail you will realize one of my patient, he had constipation since 1 month. So when he was admitted in my hospice and I inquired that are you passing stool normally? All of his family members said he is not eating only, then why he should pass the stool. So since patient has not passed stool for 1 month, that was normal for that family, because their belief was that if you are not eating, you will not pass the stool. But the fact is like this, even if you are not eating, there is a stool formation into the body every 3rd to 5th day. That is because of the bacterial activities and all. So stool is formed, and even if you are not eating, you should be able to evacuate your bowel every 3rd or 5th day. So inquire about whether they are taking any laxative, any other medicine they are taking. Is there a constipation, a recent change, और अभी अभी हुआ है कि पहले से है, what type of diet is patient. So all this detailed assessment is required. In the management, first is correct the correctable, use laxatives, that is the medicine used to evacuate the bowel. Improve general condition, symptom management, encourage activity and fiber diet, change the fiber diet. Patient should have access to a good toilet, clean toilet with privacy. Many a time this is not possible in hospital or in a when patient attends to some hospital for OPD visits and all, and so he is not able to pass stool. Timing, privacy, squatting position. Some patients prefer Indian style of toilet against our WC, and in bed, feet under knee and gentle blowing, arm resting on thigh. Encourage normal balanced diet and plenty of water. So this is common thing which I described just few minutes ago, that not eaten enough, so he will not pass stool. And as I said, the large bowel transit takes 3 to 4 days even in normal people, and stool contains shaded epithelium lining of the large bowel and bacterial action. Because of that, person has to pass stool every 3 or 5 days. So, treatment of constipation, first of all you have to do rectal examination whether patient is having hard stool or soft stool or there is no stool at all, and accordingly you have to select the drug to relieve the constipation, laxative, suppositories or enema depending on the type of stool patient has. There are number of laxatives available in our practice. Stool softeners contains usually we use is liquid paraffin, stool stimulants tablet bisacodyl, and bulk forming laxative that is isabgol, usually not used in palliative care scenario, and osmotic agent lactulose. So, depending on the patient's condition and cause of constipation, you have to select the drug. So, in paraplegic patient what they need is a regular stimulant and stool softener. Many patients require manual evacuation of the stool if it is hard stool and impacted into the rectum. So, patient with colostomy are treated with the same manner. After obstruction is excluded, you can give bisacodyl suppository and oral tablet as per requirement. So, if there is a soft stool into the rectum, use bisacodyl suppository. If it is a hard stool in the rectum, use glycerin suppository. And if there is no stool but patient is complaining of constipation, give oral stimulant or high level enema. Sometimes when patient has long standing constipation, there is a hard stool impacted into the rectum, and whatever new stool is formed in form of soft stool, it passes out from the impacted surrounding area of the impacted stool. This is called overflow diarrhea. In this situation, patient will complain of diarrhea, but in fact patient is having constipation. So, you have to do rectal examination of the patient in this condition. It is also called spurious diarrhea. In these patients, if the stool is palpable, soft stool is palpable, put a bisacodyl suppository in the rectum. If it is a hard stool palpable, glycerin suppository, bisacodyl and glycerin suppository, and plain water enema. No soap water enema is given in palliative care setup. And finally, one might have to go for manual evacuation with lubrication. In manual evacuation, you explain the procedure to the patient, give proper position, use proper lubricant, and then without causing much trauma, we should remove the impacted stool. So, after that the normal form stool will come out naturally. Thank you very much.